Good morning, good afternoon. Welcome to the final session of the ACL Care Transitions Echo Series, Care Transitions, Building Partnerships to Support Health-Related Social Needs. This is the series conclusion where we will cover future developments and have time for some celebrations. Go ahead and next slide. So again, welcome to you all for taking time out of your busy days to join us. We're very excited to have you here, and we're very excited for the program that we've developed and put together. We have a lot of great speakers and topics and presentations to cover. Again, so excited to have you with us today. Next slide. So taking a moment to look at the agenda, for those of you that have been on previous sessions, you may notice this structure is just a little different. We will certainly go through our welcome and our introductions and cover learning objectives. We will take a little time to look at who's been in the room throughout this series, as well as our traditional Menti poll questions. And then we are pleased to have two keynote speakers to touch on a couple important topics around what the future holds around care transitions, as well as leveraging Medicaid to sustain care transitions activities. We'll have an extended Q&A section for following those presentations, and then roll into a celebration. We're so pleased to have participants with us today that have been with us through the series that can share some of the achievements and accomplishments they've had throughout the series to show what they've been able to do around care transitions, and then we'll close out with resources. Next slide. So first, introductions, and as always with our sessions, we do want to start by having you introduce yourself. Please go ahead and type your name into the chat and your organization. If you have a series partner with you today, please let us know. And feel free to share again an action that you took since the last ECHO event. And while those chats are coming in and those introductions are coming in, want to take a moment again to introduce myself as John Jansa, as Care Transitions Task Lead, facilitating today along with my co-facilitator, Heather Johnson from Facila Solutions, and as well as the rest of the ACL Care Transitions team, Monet Bryant, Amy Goodall-Douglas, Kristen Vangeloff, and Sarah Sargent, supporting our session today. Certainly want to take a moment to recognize our speakers, Tim McNeil from Freedmen's Health, and Christina Neal-Bowen, who is part of the Lewin TA team, and our participants. We're so pleased to have representatives from Southwestern Connecticut Area Agency on Aging and Yale New Haven Health from Connecticut, as well as representatives from the representative from City of Issaquah, Washington, and Virginia Mason Hospital. We'll also have a short presentation from Coordinated Care Alliance and Ascension St. Mary Hospital in Illinois, and then Elder Options in Florida. We're going to have 4 short presentations from each of them talking about some of their successes throughout this learning series. So just taking a look at the chat, so many, great to see some familiar faces. Rebecca from Partners in Care out in San Fernando, California, thank you for joining us today. And Jennifer Cotton, thank you for joining us again. We realize that this session falls right during the HCBS conference. So we're so pleased that so many of you were able to join us today for this session. So let's go ahead and move to the next slide. We'll just briefly cover housekeeping rules. Again, active engagement is always encouraged. Cameras on if you're comfortable. Please do your best to minimize distractions. And also, while we certainly want you to share, there's no right or wrong answers. We do ask you to be careful and not share any PHI or PII. Closed captioning is available via Zoom, and leverage all the tools we have to facilitate dialogue. If you want to come off camera and share vocally what you want to share, that's fine. You can use the chat. Feel free to ask questions, and we'll do our best to engage and keep everyone connected. Next slide. So real quickly, we'll go through the learning objectives for today's session. We do want to review and provide an update. We have done a lot since January, and there is a lot to cover, as well as to provide updates on forthcoming and related policies related to care transitions that may benefit your work going forward. We want to highlight ongoing opportunities to strengthen community partnerships. We also want to take time to talk about how to leverage Medicaid. We know sustainability is such an important piece of the puzzle, and we feel that it's important to talk about how to leverage Medicaid, including Medicaid administrative claiming, that can support or sustain transition activities. And as I said, one of our objectives today is really engage in a celebration from our participants who are speaking, but also from you. You're welcome to share any successes, big and small, accomplishments, big and small, because we want to use this opportunity to come together collectively and revel in what everyone has been able to accomplish. This is not an easy job to do. With that, I'm going to transition over to Heather, who's going to take us through some of the summary information from the series and our participants. Heather?
Great, thank you, John. We just wanted to give you a sense of, from the very beginning, who enrolled in this series. And you can see here, these are not unduplicated numbers. We, from our original needs assessment, captured organizational types. And you see here that this is a self-identification across categories. So we had 125 healthcare providers, of which some might have self-identified as hospitals, ACOs, or other. And then we also had categories of community-based organizations, which were inclusive of area agencies on aging, some of you of which are also community care hubs or network lead entities. You also might be an aging and disability resource center or part of a partnership that makes up an ADRC. We have centers for independent living and then other categories. So we were very happy to see the diversity and know that there are some long-term sustaining relationships that are beginning as a result of these partnerships. So if we can go to the next slide, just wanted to give you a view of where we are across the country. We had a considerable number of states represented in this series. We had high concentrations of folks across California, Illinois, Pennsylvania, and Florida, as well as Oklahoma, for example. So we were very pleased with the diversity of participation across the country, and know that we're going to hear from some of these folks today. So with that, let's go to the next slide. And we'd like to jump right into a Menti poll, which we will be sharing the results later on after we've completed our celebration. We'd like you to go to menti.com and use the code 9866-7619, or you can use the QR code on the screen with your phone and answer the question, what is the most valuable lesson, tool, or strategy you learned during this series? We'd love to take this into consideration. You can also include in here things that you feel that you'd still like to learn. So use this opportunity to go in and give us some of your feedback, and we will be taking this back. And I know that the Administration for Community Living is very eager to hear your responses to these questions. So with that, I'll leave this Menti poll open. I'm seeing some coming in as we speak, and we will now move forward with the rest of our presentation. I would like to, at this opportunity, now introduce Tim McNeil. You have all heard from him on prior events, and he's going to give us a little bit of a view into what does the future hold. So Tim, welcome, and we'll turn it to you.
Great, thanks so much. So I will provide some information. Well, first recap all the great learning that you've had throughout the series, and then talk about where we go from here as it relates to health-related social needs and its impact on hospitals and community-based organizations organized into delivery systems. Next slide. So first, in terms of the recap, I want to circle back to the inpatient prospective payment system rules, which really started the process where hospitals had to begin considering a process to screen for health-related social needs, and then also talk about the physician fee schedule and its impact. Next slide. So as you recall, in the inpatient prospective payment system rules, it required hospitals to begin screening for health-related social needs for any person over the age of 18 admitted to a hospital, and has to be over 18 on the day of the admission. Initially in FY23, it was a voluntary process, which then moved to mandatory for FY24, and then we'll begin penalties. for FY25 for hospitals that do not report. And so it does require this screening for social drivers of health, and then a reporting on the percentage of the population that was screened, and separately the percentage of the population that screened positive in 5 domains. Next slide. So first of the measure was that the facility's commitment to health equity. This is part of a broader health equity agenda where there's multiple things, policy perspective, to drive equity, and that equity also has a key financial impact, because improving health with a focus on equity also reduces costs and improve outcomes for the whole population. So first domain is establishing equity as a strategic priority, data collection to include demographic data on health-related social needs and other things, the analysis of that data, incorporating that into a broader quality improvement strategy, and having leadership engaged. So an example of that is looking at things like readmissions, and then the overlay of those readmissions, persons who had one or more social needs, and are there differences in the readmission trends based on the demographic data or other factors? And then are there things that we as a facility could do to better address the needs of the population when there are differences in the outcome data based on some of those demographic trends? That's an example of measure 1 of facilities' commitment to health equity. Next slide. So the measure 2 is the screening for social drivers of health. So as a repeat, there's 5 different evidence-based domains for health-related social needs. That includes food insecurity, housing, transportation needs, utility difficulties, and interpersonal safety. So the measure is to screen and then report the results of the screen in each of those individual domains, where each domain is a separate report as part of the broader quality measures. And the intent of that measure is to promote adoption of the screening. This first measure is just the screening activity. It doesn't capture data around the outcomes of the screening. That is a separate measure. And so the desired outcome is that there's this increased level of screening. And then ideally, as we screen and identify needs, there are linkages between hospitals and community-based organizations that have organized into delivery systems to address identified needs, particularly when those needs are impacting patient care or the ability to transition people back to community settings. Next slide. Then separate from that is the screening for positive rate for social drivers. And this requires a reporting of not the results of the screen that are positive. And that is also reported in each of the 5 domains, where the intent of that measure is to capture the magnitude. So one is screening activity, and then separate from that is the impact or magnitude of the health-related social needs amongst the people that we serve. So looking at trends in the data, where we may identify that the trends are showing there's a significant population that maybe has food insecurity or housing insecurity, and then matching community resources to see, do we have resources to address those needs, with a correlation on its impact in clinical quality measures, whether that be things like readmissions, length of stay, and other activities. Next slide. So with all of this emphasis on screening and identifying the outcomes of the screening, the Centers for Medicare and Medicaid Services for calendar year 2024 established new payment policies to specifically create a pathway for reimbursement for addressing health-related social needs, which is the Community Health Integration Codes. It is a Part B benefit, specifically for persons who have a health-related social need. I want to point out that in the list of eligible services under Community Health Integration, CMS specifically listed transitions of care as an activity when a health-related social need impacts the ability of an organization to transition someone from an acute care hospital to community or an institutional site back to community, that you can leverage this benefit as a payment pathway for the labor to address the health-related social needs. Separate from the community health integration is screening for their needs, which is the social determinants of health risk assessment. All of these are Part B, as employee benefits, and principal illness navigation, which is for persons who have a high-risk condition that's expected to last at least 3 months. Examples of that was dementia, heart failure, diabetes, and other factors. And then lastly, principal illness navigation peer support, which, as a reminder, is for persons who have a behavioral health or substance use disorder, and it's specifically a benefit for the labor of trained peer support workers. Under the fee schedule, CMS created a pathway for Part B providers to contract with community-based organizations. CMS specifically listed that in the rules and gave examples of community-based organizations that could be considered partners. We kind of pointed out that whether you have an integrated health system or health systems that have clinical sites that are delivering outpatient care, a partnership between the inpatient side and the outpatient care delivery, whether that be a resident clinic, a transition clinic, or an outpatient clinic that's part of a broader medical group that's affiliated with the hospital. Those are pathways to trigger reimbursement to support transitions of care, particularly addressing health-related social needs or navigation needs that are impacting a discharge from the hospital or an observation stay. These codes can be built concurrently with transitional care management and other care management billing codes, such as chronic care management. So it really creates a pathway to sustain a whole person care model where their social needs and addressing those social needs is directly reimbursable as part of a broader whole person care strategy. Next slide. So now that we've recapped all of the information regarding requirements for hospitals to screen, reporting the results of positive screens, as well as highlighting the payment pathways under Medicare Part B, we had not talked a lot about options for Medicaid. And as a hospital is repeating that requirement to screen for health-related social needs for all persons over age 18 will include the Medicare population, but obviously persons that are not Medicare eligible. And so we've also wanted to point out options under Medicaid, and then also at the end recap some opportunities under Medicare Advantage. So some of the options under Medicaid creates a pathway, but it is dependent on flexibilities that the state has elected to choose under additional flexibility that's offered from the Centers for Medicaid and CHIP services at CMS. Next slide. So if you're familiar with that term 1115 waivers, in many states, and you see all of the states that are listed on the screen, and these states are either have an existing 1115 waiver, or they have a pending application, or some states have an approved 1115 waiver and are modifying that. So they have a current approved, and then they have pending modifications to their existing 1115 waiver to provide other services. So under the increased flexibility in the 1115 waiver, the Centers for Medicaid and CHIP services is creating a pathway for states that want to elect as a healthcare benefit that would also roll through to the managed care organizations to address health-related social needs as part of Medicaid. Some of those health-related social needs provisions that can be covered under an optional 1115 waiver includes things such as housing supports, nutrition supports, and other services. So if you think about hospitals are ramping up their screening, identifying many persons who have health-related social needs, and now under Medicare, through billing for community health integration and other services, and under Medicaid with expanded flexibility under 1115 waivers, it creates a pathway for reimbursement for deploying interventions to specifically address identified needs in the hospital. So that could be part of the toolkit or the decision tree. As we're screening and ramping up screening, we now have a positive. Does this person, are we operating in a state that has an existing 1115 waiver? Does this person have Medicaid? Yes or no? Is the need, the social need, included in our state waiver? And who are those community partners that can bill or receive reimbursement under that 1115 waiver? And then having that list of those options available to our discharge planners and case management team so that they know how best to facilitate the care as we're ramping up the screening for social needs. Next slide. So I want to go through some examples of Medicaid state innovations where the state Medicaid authority has decided to use the 1115 waiver process to incorporate benefits to address health-related social needs, and then just point out the overlay between persons that are admitted to an acute care hospital or have an observation stay in the emergency department. And now we've identified that they have social needs, health-related social needs. And if that person that's admitted also is enrolled in Medicaid, depending on your state waiver, there's additional options to support the services they may need to facilitate that transition to a community setting. So highlighting in Arizona, the Arizona Healthcare Cost Containment System Housing and Health Opportunities Demonstration and Targeted Investment 2.0 program. So in Arizona, under their 1115 waiver authority, they decided and got approved for enhanced and expanding housing services and interventions to address members who are homeless or at risk of becoming homeless. So now this person who's admitted to the hospital, who has housing insecurity and is enrolled in Medicaid, if I'm a hospital in Arizona, I want to understand the network of organizations approved under the 1115 waiver to provide that expanded housing services and interventions. And then once we identify persons that are homeless or at risk of homelessness that are in my acute care hospital, I would link to those programs as part of my discharge planning process, knowing that there's a payment mechanism to support that expanded housing services that is complicated based on an admission. For hospitals in California, the CalAIM 1115 waiver, in their waiver, they included a range of community supports to include recuperative care and short-term post-hospitalization housing. So now this person who has Medicaid, who may have had a surgical procedure or other things, who was homeless or had a history of being unhoused before they're admitted, now using this waiver authority, there could be short-term post-hospitalization housing to facilitate a safe discharge, but that would require the hospital engaging in contracting with community-based organizations that are participating in that waiver, or identifying community care hubs, because California is another state where they're actively encouraging the growth of community care hubs to implement these 1115 waivers under Medi-Cal. And then through that single contracting with the community care hub, we'd have access to a range of services that are covered under the 1115 waiver. I want to note that California, although they have an existing 1115 waiver, they're also looking to make changes to that and enhance their existing waiver. And so you should be following that closely. One of the things that they're proposing is a community health worker benefit, and that community health worker benefit could potentially provide a pathway for hospitals to have additional supports for Medicaid beneficiaries using community health worker labor that would be reimbursable. But that additional 1115 waiver is not yet approved, so you should be tracking that so that you know once that is approved, additional services that could be leveraged to facilitate transitions. Next slide. In Massachusetts, in their 1115 demonstration waiver, they also include housing supports, case management, outreach and education, and nutrition sustaining supports. So in that market, the overlay, the matching would be people that screen positive for food insecurity. And now in a state like Massachusetts that has nutrition sustaining support as a 1115 waiver benefit, then that could become the intervention for that person who had a positive screen that you're reporting as part of your requirements, but also as part of your discharge plan and establishing a safe discharge, you'd be leveraging these 1115 waiver benefits to provide those additional supports, such as pre-procedure and post-hospitalization care, housing supports, and case management. I'll give you an example. I was working with a site and they had a person who had a history of homelessness who needed a surgical procedure. And they did not feel that it was going to be safe to do that procedure. But like in a state like Massachusetts, there could be these pre-procedure supports, then a planned admission for that procedure, and then post-hospitalization care. So you could see how that entire episode of care would be better supported for a person at risk if we leverage these types of flexibilities. For states that don't yet have an 1115 waiver or another benefit that I'm going to talk about later called in lieu of services, you may want to talk to your states about the potential impact of not having these tools on hospitals, because a big part of the 1115 waiver and the other benefit called in lieu of services is the fact that it has to be cost effective, and cost effective usually looks at the impact on these benefits on reducing unnecessary admissions and readmissions. Michigan is another state where there's a range of support services to provide housing security and stabilization. Things such as security deposits for persons who require security deposit in order to establish housing. Also things such as utilities and other essential furnishings. In my work with hospitals, I hear quite frequently persons that are sent to emergency departments for quote unquote social admissions because they have, utilities, but they're on oxygen and they can't remain in their home if the power is out, if they're oxygen dependent. Those types of things where we could leverage these waivers to then facilitate that person moving from your emergency department back to their community as fast as possible when they have Medicaid as their primary insurance, and now they're sent to the hospital because of factors like their utilities are out, but they can't be without their utilities in order to sustain their life-saving measures. North Carolina is another state where through their Healthy Opportunities pilot, there's a range of social drivers of health screening and intervention such as housing and nutrition, intervention to address interpersonal violence and transportation. You may see right off the bat how that matches exactly to the CMS screening requirements for hospitals, where from a hospital in North Carolina, I'm required under the inpatient prospective payment system rules, screen for housing, nutrition, interpersonal violence, transportation, utilities. And now under the Medicaid 1115 waiver demonstration, we can address those needs for the Medicaid population. Next slide. Separate from the 1115 waiver process, CMS, the Centers for Medicare and Medicaid Services, have rolled out another way that states can provide innovation under the Medicaid program to address health-related social needs. And that's under something called in lieu of services, or ILOS, which is another way that is commonly referred to. And states under the Medicaid program and Medicaid managed care plans, they'll have additional flexibility to propose substitutes for services or settings to cover services under their state plan as an in lieu of. So the way to think about that is, if I'm state Medicaid, if I cover a service such as housing instability as an in lieu of service, there is an expectation that there will be a reduction in other services. So I'll provide housing supports in lieu of what would happen if I don't have the housing supports. So that the same example of a person who has a history of homelessness and now is having repeat admissions to the hospital. If I'm able to stabilize their housing, then that may prevent unnecessary hospitalizations. So that additional housing expense in lieu of additional admissions is oftentimes a more cost-effective way to service the needs of the Medicaid population. And CMS is creating a pathway for states under this in lieu of service flexibility to add those benefits. So if you're in this, or if you or your hospital, or oftentimes the hospital association in a particular state may be in conversation with Medicaid about in lieu of service. This is a hot topic in the Medicaid world, and making the case of the need for these services such as housing and nutrition supports as an in lieu of service benefit, and how it can potentially support hospitals to address the needs of the Medicaid population as we're ramping up screening, is a key way to help move or advocate for expanded use of in lieu of services. So as a specific way to address the impact on hospitals for unnecessary admissions and readmissions. The in lieu of service, the third bullet there talks about, it does also have a requirement for cost effectiveness. So as states are thinking about proposing in lieu of services, they have to also propose how those in lieu of services will be cost effective. Cost effectiveness means that by paying for that in lieu of service as a Medicaid benefit, that there will be a high likelihood that there will be a reduction in the total cost for Medicaid beneficiaries. And oftentimes states propose in lieu of services with the expectation that the provision of the in lieu of service will lead to a reduction in unnecessary hospitalizations, a reduction in unnecessary ED visits, and a reduction in readmissions. And so since that is oftentimes the proposed way to create cost effectiveness, it's very important to get input from hospitals of what are the types of services that you think will lead to improve service delivery to the Medicaid population that will lead to reductions in utilization for the Medicaid population. Your data around screening for health-related social needs, the positive rate, the types of needs, all could be leveraged as part of a discussions with Medicaid for the creation of either 1115 waiver or in lieu of service benefits. So that data is essential for states that are considering this. A memo went out to all state Medicaid directors, encouraging them to consider leveraging in lieu of services as a way to provide expanded health-related social needs to the priority population of Medicaid beneficiaries. And there's been multiple webinars for Medicaid directors, and many states, just like states that are implementing 1115 waivers, many states are considering the in lieu of service. Next slide. These next two slides, I'm at time, so I ran over. These next two slides highlight under in lieu of services, things that the Centers for Medicare and Medicaid Services have sent to states saying that they are eligible for coverage under in lieu of services. A full list is at the link. This list was just updated in November of 2023. You see a range of housing supports under in lieu of services or 1115 waivers is allowable expenses. Next slide. This next slide speaks about food insecurity. So there's a range of food insecurity options that are available. Next slide. So through this strengthening of partnerships between hospitals and community-based organizations, just last two slides, just want to point out that it really is a process of blending and braiding. We obviously won't have all of our discharges that are Medicare eligible. Not all of our discharges will be Medicaid eligible, but to the extent when they have Medicare, we have resources to address those health-related social needs through Part B. When they have Medicaid, leveraging in lieu of services or 1115 waiver and other state plan authorities is another pathway. And then there's other revenue streams, because the expectation is that we will blend and braid multiple resources to address the needs of the population. And all of these options will be available to your case management and discharge planning team so they can best meet the needs of the population as we're ramping up screening. Then the last slide is a decision tree. So from left to right, where patients that are having a positive screen, whether they're in the middle, Medicare, fee-for-service, or dual eligible with Medicare as a primary payer. We would be leveraging those Part B benefits, such as community health integration, principal-less navigation, in partnership with those outpatient providers or a hospital-owned practice. Medicaid, middle bullet, is looking at additional flexibilities under 1115 waiver in lieu of service. And then Medicare Advantage, there's additional flexibility on something called special supplemental benefits for the chronically ill. And so there now, with all of this additional flexibility and payment pathways for addressing health-related social needs, it gives a pathway to address the needs as hospitals are ramping up screening and partnering with community-based organizations that can help implement these things in a sustainable manner, leveraging blending and braided funding strategy. So I'll pass it back over to my colleagues at Lewin now.
Thank you so much, Tim. I'm now happy to introduce our colleague, Christina Neal Bowen, and she's going to take us through an overview of how to leverage Medicaid administrative claiming. So Christina.
Thanks so much, Heather. And sort of to pick up on where Tim left off, I'm going to talk to you about a funding stream that is not new, not any new flexibility or new CMS rule, but it's called Medicaid administrative claiming. And it is not fee for service or claiming for a service. But if you go to the next slide, Medicaid administrative claiming is reimbursement for anything that is done to contribute to the efficient and effective administration of the Medicaid program. So it's been around a really long time. Many states have this in place. It takes place in the school systems and the criminal justice system. It's really those activities that relate to explaining the Medicaid program to someone and helping to facilitate application or discussing with them if they want to pursue Medicaid as one of their options for support. So many of the functions that your care transition staff or your discharge planners or your local CBOs are doing are eligible for this reimbursement, and it is a reimbursement. So in many cases, you're doing this and you are able to get reimbursed from your state Medicaid agency to do it. So if you are able to get it in place, it's really nice because it's sustainable. It's not a grant. It doesn't sunset. It's just, you have to, the challenge is getting it in place. So if you go to the next slide, I want to show you where this is happening right now that we know of. So ACL has been in communication with states relative to their no wrong door systems. And here's what we know. And this is all self-report from states, but the blue states here are states where this capacity is in place for the state's access system. So this is either happening at area agencies on aging, centers for independent living, ADRCs, organizations that are part of the access system. And the states in the orange are planning for this. So for example, I'm helping California right now set this up so that it can happen for them statewide in their access system. So the next slide kind of details the types of activities. So I mentioned anything that has to do with talking to someone about the Medicaid program or helping them decide whether or not they want to apply. This would involve conversations you might have about state recovery or any Medicaid rules that people would want to know about. So this is really relevant to discharge because you're having those conversations about what community supports can you get in place? Is Medicaid one of your options? If the person is on Medicaid, you can actually get reimbursed for helping them connect them to Medicaid services. But if they're not on Medicaid, you can be reimbursed for helping them make that decision, for helping them understand the application process, even for helping them fill out an application with which many of you might already be helping with. So these are the types of activities here on the slide that relate to care transitions. Next slide. So the key with Medicaid admin funds, so different than service claiming where, the percentage of state match aligns with sort of the state's, wealth or not. This claiming is 50-50. So 50 from the federal government and 50 from the state or local. And so one thing we wanted to point out on this is that the only requirement for match is that it not be matched with federal funds. So that means that state general revenue can be used, local funds, county funds, even funds that a hospital might contribute could also be used as match. Foundation support. So, it's really a very flexible, and it kind of fills in those cracks. Tim's last slide with the different pathways, this would be something that could kind of fill in the cracks, but is not service claiming. So I just want to be very clear about this. So this would be a process of, if you go to the next slide, how would you set this up, or how would you go about looking into this? So you would want to look at the map and see, where your state is. So if your state is blue, they're already claiming, or orange, they're planning. We encourage you to reach out to ACL at the email address here, and we will help you connect with the people in your state who are implementing this and could potentially add you into the existing claiming that they're doing. And in many cases, you have to justify and prove that, you're basically tracking your time to say, this much of this staff person's time was Medicaid related. So that was very quick. I know we don't have too much time, but as John put in the chat, we will have a Q&A too, but we encourage you to reach out and let us help connect you with the folks in your state responsible for claiming. John, back to you.
Thank you, Christina, and thank you, Tim, both for some really good content, something for a lot of our attendees to think about. We do have time, and we have built in extended time to have a Q&A. So I know Tim covered a lot of ground in his presentation, and Christina touched on a really important piece in the sustainability puzzle, this Medicaid claiming. So we're leaving it open for people to ask questions, to come off mute. We did get some questions submitted ahead of time, so I will go ahead and just raise up the first one. Brianna over in Oregon, she had a question, sort of a comment, saying that they have quite robust CHW program at their organization, and they're struggling to find the codes we can use to capture billing and revenue to help see that this is to see their programs are self-sustaining. And she basically says that she's seen some presentations from other organizations that have figured this out. Is there anyone that can help with this? She has reviewed the transitional codes and complex care, etc., but feel like they're missing something. Brianna, I don't know if you have anything to add, if you want to come off mute, but I will just say, first and foremost, you certainly can register if you haven't already to the TA community site and look at past presentations that we've had from some of our partners, including them from Illinois, from Oregon, that you might be able to find a partner organization. But Tim, it sounds like a question directed to you in terms of making sense, or how to make sense of these codes in a way, if there's a gap or some bit of knowledge that you can share to kind of help connect the dots in terms of these codes.
Sure, and Oregon is one of the states where you're fortunate that there's expanded 1115 waiver authority. There's an in lieu of service authority where the state has clearly recognized the impact of health-related social needs. A lot of that is focused on persons who are having acute hospital admissions and readmissions and high utilizers, so that the pathway, one, there is technical assistance that can be made available. We have been supporting sites in Oregon for multiple years, but quickly the pathway under the transitional care management and community health integration codes for Medicare, they specifically allow for auxiliary personnel, and the types of auxiliary personnel that can deliver the services that's reimbursable under general supervision in an outpatient provider includes community health workers. They specifically outline community health workers as eligible auxiliary personnel that would help deliver those services. Separate from that, under the 1115 waiver and in lieu of service that's authorized within the state of Oregon, they call them CCOs or coordinated care organizations, which in other states they call it MCOs. Through each of those CCOs, they're required to screen for health-related social needs and contract with providers to address those needs. A lot of that discussion is also about leveraging community health worker workforce. So I would encourage you to talk to the largest CCOs in your service area and then present to them that not only can your hospital supports expanded screening, but you have a community health worker workforce that can help with the screening and addressing the needs. That's part of the 1115 waiver and in lieu of service, which creates a second pathway for reimbursement for Medicaid beneficiaries in your state.
That's great.
Thank you. I think so. We're an outpatient primary care facility,
Okay, great.
and our supervisor of this community health worker program is fantastic, super knowledgeable. Like, she has talked about all of these things that you're mentioning here and the codes, and we're kind of building. So I feel like I don't know what the disconnect is. It's like there's these mystery codes, some like diagnosis codes or something that we're chasing down, because even having this understanding, we're not able to bill for their services. So maybe I can reach out offline to kind of talk through more specifics, or
Absolutely.
yeah, okay.
So we'd be happy to talk you through that. And we have lots of experience working with outpatient practices. To implement this, it's really built for outpatient practices. And so the rules are confusing, or they can be confusing. I'll say that. But yes, please reach out.
We did get a question in, Christina, about Medicaid claiming. We did see the map that you shared, showing that there are states that are pending or in the process of setting up administrative claiming. And Tammy asked, is there an expected go live date for California to implement administrative claiming?
Yeah, thanks for that question, Tammy. So we're working with the State Unit on Aging right now and the State Medicaid Agency. And so I think their hope is to submit something to CMS within the next year. But I still encourage you to reach out and maybe we can have a call, because we can kind of explain further what's going on. Right now, they're doing a time study. So we may be able to put you in touch with some of the folks that are looking to work that out in California. In California, they have some designated ADRCs, which are a partnership between area agencies on aging and independent living centers, and some that are emerging. So it also depends kind of where you are in the state, but happy to chat more about it. Thanks for your interest.
I wanted to ask if I could, Christina, a follow-up question. We know this process to set up and establish administrative claiming. It is a process to engage with the state. Do you have any guidance just in terms for someone that's in a state perhaps that is going to take on the task of engaging? What's a reasonable expectation for how long a state could take to sort of roll through the processes and get this established?
That's a great question. So we have some examples of states that have done this really quickly, like within a year to 6 months, like New York and Nebraska recently did. And then other states, Hawaii just got approved, but they had been working on it for about 3 or 4 years. So it's a pretty big range. But the good news is that in those states where it's established, it's really just a matter of connecting in to the established pathways. And I also saw the question from Virginia, so they're starting to think about it again too. So we can definitely connect you with the state folks in Virginia who are starting to look at that too. So it's I wish I had a better solid answer, but there's a real variety of time frames.
Well, that's fair. It's the if you've seen one state's Medicaid program joke, if you've seen one state's Medicaid program, you've seen one state's Medicaid program. So understood. I do want to take a moment to just open up the the opportunity for anyone if you want to chime in with a question to Christina or Tim. I don't see any more. I think, yeah, if you have an additional question for Tim or Christina on the content that's been supplied, we have time to have those questions asked. So feel free to jump in. I'll give everyone a moment.
Christina, hi, this is Ray Manahan from the state of Washington. I haven't looked into those websites that you provided in the slides, so I do plan to look at those. But do those also list not only the admin offices like at the state of Washington Medicaid office, but do they also have the listed community-based organizations who have an interest in these programs? Because I haven't heard anything from our CBOs regarding this. If there's an opportunity to connect them, I'd like to pursue it.
Yeah, so Washington is a state that has had this in place since the 90s. So it may just be like so much of their normal process that they're not thinking about it. But Ray, if you wanted to have a conversation with Ami Patel from ACL, who is, really leads this, and myself, we'd be happy to connect you with the folks at the State Unit on Aging in Washington, and make sure that you get connected to see how you can plug in if possible.
Great, thank you.
Mm-hmm.
And I'll just point out, Christina, and we'll hear from Ray here shortly, but Ray, I'm sure you saw the part of the slide with the source of funds for match can be a local source, of which I know you are local. So it would be interesting to see. And Christina, just on that note, are you aware of any states that actually are using local sources that might be a good reference for Ray, just off the top of your head? Otherwise, he could probably follow up without me directly.
Yeah, we do have that list off the top of my head. I don't know. We have a spreadsheet where we kind of track, what is the source of local match, and then also what the states are using the reimbursement for, which is a really nice feature of this type of funding source. There's no restrictions on that. So when you get reimbursed as an organization, it can kind of go for whatever you want it to go for. So one of our star shining examples is we have some partners in Nebraska from the Traumatic Brain Injury Association, and they are getting so much match that they're going to be hiring 2 new staff for the coming fiscal year. So they really do a lot of that outreach and information to people with traumatic brain injury about Medicaid. So it's really, really paying off for them.
Well, I so appreciate, Tim. There's so much to cover. You've certainly covered them in past presentations. We appreciate asking anyone to cover all of those concepts in a short amount of time. It's a challenge. So thank you so much for taking us through that. Christina, certainly with Medicaid claiming, appreciate your presentation. I do want to reiterate a couple items as we get ready to transition into the next segment. We do have our resources slide at the end. We have included, we've expanded that resources slide, this being our last session. And we have included, there are links to a lot of resources that are already on the TA community site about Medicaid claiming. So Brianna or anyone else, if you are looking for additional resources or opportunities to learn more about Medicaid claiming, there are links provided in the resources, as well as links to other resources, including Tim's past presentations on some of these topics. So again, thank you, Tim. Christina, appreciate the questions that have come in. We are going to now transition over to our next segment, a celebration of our participants. And Heather, I'll kick it over to you.
Great. Thank you so much, John. And we are so excited for this portion of our agenda. Certainly we want this to be known that this is a celebration of everyone who participated in this series. And we want you to hear from you in addition to our featured celebrants. We have a few to share their journey. We've observed their journeys through our peer working sessions and through interactions in between. We've even had some of these folks present because of the work that they've actually accomplished in between and are growing and evolving. And we know, and I've seen, which we'll share momentarily in the Menti poll, that many of you and in the chat and introductions, you are all making great progress. So what we'd like to do is hear from each of these, and then we're going to open it up and would love to hear just any questions for the participants or you sharing your own successes and things that you're proud of. So first, what we'd love to do is turn it over to our Connecticut colleagues, and I will turn it over to Shannon and Brian. So if we can go to the next slide.
Wonderful. Thank you, Heather. Hello, everybody. It's a pleasure to be here with you today. I'm Shannon Jordan from the Southwestern Connecticut Agency on Aging, and my partner in crime for today's purposes will be Brian Gomez from Yale New Haven Health. So let's get started. Next slide, please. So as we all know, we began January 2024. SWACA and Yale New Haven Health joined forces to participate in the ACL Care Transitions Echo Series with a shared vision to support positive health outcomes for adults and decrease hospital readmissions related to social determinants of health. We at SWACA have well-seasoned social workers who are ready to provide timely interventions with direct access to our programming and our strong community partnerships, yet we struggled with timely access to referrals and a committed payer source for services. Next slide.
All right, I'll go ahead and share. So just a quick introduction. A lot of you have seen Andrew on the calls a lot of the time. So I'm speaking in this place. My name is Brian Gomez. I'm a Community Health Project Coordinator for Yale New Haven Health System, Bridgeport Hospital. So just speak on the health systems, and so we at Yale New Haven Health System have recognized us being an anchor institution that is rooted in the communities that it serves, really are continually committed towards working on serving the community and what that actually looks like in terms of our most vulnerable populations, meaning those social drivers of health. We've also, gone on the path the past 5 years or so towards health equity and really zoning in on that. But at the same time, throughout this process, we've realized that we absolutely cannot do this on our own. That's something that's been reinforced time and time again. Meeting these needs, it really does take a village, and it takes an interdisciplinary care team that spans outside of our walls. And so how do we challenge each other, challenge our leaders, and encourage one another to really bring in CBOs like the Agency on Aging from the outside to be a part of that care team and really be inclusive. We've leveraged our monthly partnership check-ins. This is one of the successes that we've had. We've really leveraged them for the sake of relationship building between the partners. And one of the things that came out of that is a training curriculum for our Bridgeport Hospital CHW teams to ensure that they are better equipped in terms of serving the needs of these patients when it comes to post-discharge and the reintegration back into the community. So next slide, we'll go back to Shannon.
Okay. And again, we have enjoyed multiple opportunities and multiple relationships between SWACA and Yale New Haven Health. One of these relationships led to the opportunity to implement a pilot care transitions program at Bridgeport Hospital with funding for the pilot previously secured through a one-time grant. Workflow was established by Bridgeport Hospital and SWACA. Designated SWACA staff successfully completed Yale New Haven Health's extensive credentialing process, allowing staff to visit patients bedside upon referral from hospital staff. SWACA and Bridgeport Hospital are scheduled, not later this month, scheduled next week to begin this program with introductions between the two teams happening tomorrow. Next slide.
So where do we go from here? What are some of the next steps? So when Andrew returns from being on leave, we want to speak with our Pop Health team and explore in partnership what are the main reporting metrics that make the most sense based off our history of screening for social needs, as well as just the building of this partnership, so that we can demonstrate what that collective impact looks like, so that we can launch more than just a pilot and demonstrate the potential success of this program and this work in the efforts of really securing sustainable funding as we go down the path of identifying the appropriate procedure codes for billing and securing a payer source that really helps us out with the future of care transitions programming. We also want to work toward the more effective data/information exchange. There were challenges that were spoken to earlier in previous sessions about that read-only access in Epic. And so what does that look like in terms of further exploring with the Epic team, with our leaders? How do we transform the way we deliver care to ensure that information exchange is more fluid, more coordinated, so to speak? And then lastly, continued collaboration on meaningful programs and services that will grow and strengthen existing connection between Southwestern Connecticut Agency on Aging and the Yale New Haven Health System. And we've had a history for the past several years of working together kind of informally, so to speak, when it comes to our partnership. Now, how do we really get more serious about it? This doesn't, the road doesn't end here. And this is something that we want to see continue to transform for years to come.
Thank you both so much. It's so incredible to hear your journey just over these short 8 months. And I know it probably seems like a long time, but that's a lot that you've done. I will share actually that in our last peer working session, Shannon shared the fact that they actually completed the last peer working resource and was able to present it to the colleagues on that breakout session. So nice work, everyone, with what you've accomplished. So with that, I'd like to now turn it over to Ray, and Ray's going to talk through a partnership and work that he's been actively pursuing for some time. So with that, Ray, it's over to you.
Thank you, Heather, and thank you, everybody. Good morning, good afternoon. It's a pleasure to speak to you today. So just the first slide here, I've been in healthcare for many, many years, but really what brought me to this endeavor was most of my focus has been on population health. And I think all of us on the line are aware of what population health is all about. It's to improve the provider experience, it's to improve patient experience, it's to decrease cost of care, and it's to produce better outcomes. And I think what's working here with this program is what stands out to me is how they all align with those parts of the quadruple aim in population health. It's an ongoing journey, very challenging. And I thought that the work that's going on here really has helped to move it forward. But what brought me here was not the work that I did with healthcare organizations, interestingly enough, but it's the work that I do as an equity board member for the city of Issaquah, which is a large growing area east of the Seattle area. So next slide, please, and I'll elaborate on these. I first wanted to call out from the meeting series, and I'm going to ask my partner in this because I made a great contact with Virginia Mason, CHI Franciscan Health, Jen Fletcher. I'm going to ask her to comment a little bit, but just an explanation of my emojis here. For me, the successes certainly, and I credit Mr. McNeil, Tim McNeil, and the others who shared the complex information and were able to simplify it to a level that we can take to others. So for the presenters and the tools that were provided, the partnership resources, the sample contracts, the referral workload documents, I've really looked at those and shared it with other organizations, and it's really helped narrate what this is all about in a simplified manner. So thank you for that. The complexity behind these physician fee schedules, I don't know if I suspect most of you have gone through a couple of those, but they're very, very complex. So to be able to connect this endeavor to what's going on with CMS is hugely key. I know they're constantly changing. So to make the connection with what the fee schedule looks like today and it's going to mature into in the subsequent years as it relates to this work was really important to me too. And then obviously those peer group sessions that we have, where we can share with one another what's going on in our region, I found those of incredible value. So thank you for coordinating those to the leadership team here. To the right, I think what's been successful for me are local and national civic leadership. I mean, I have a direct line to the mayor in our city and also the different committee chairs. the councils that exist and been able to share this work, and they found great value in it. And through them, I've been able to connect with the community-based organizations. So I sit in on the Health and Human Services Committee that report up to the mayor and the city council, have been able to share the work and create some partnership with some local CBOs. And they have found this information really, really informative. So those conversations will continue here in our region. What I think my challenge has been with the healthcare delivery organizations, there are several that I'll explain a little bit more in the next slides, but because healthcare delivery organizations can be so large, I think sometimes the challenges are, this is not a local endeavor, but one that has to pass through kind of a higher up. So we're talking about the C-suite because of the resources that need to get involved, because of the contracts. So that's been a challenge, but I'm going to continue to tackle that. And because through the past 8 months, it resulted in no contracts. I need to rethink the approach here, maybe to pull in some other folks and maybe not start with such a large organization, but maybe focused on the local ones. And I'm talking about rural health clinics and federally qualified health centers, FQHCs. I think there's a strong interest in those healthcare delivery organizations in this work. So I think there's a lot of opportunity there. Even though I got no contract, I'm still excited to continue this work. And I want to pause here because my partner in this work, I'm so happy to have connected with them, is Virginia Mason, a very large healthcare system here in the Puget Sound area. They're connected with CHI Franciscan Health and their larger organization, which is Common Spirit Health. So Jen Fletcher, if you're on the line, I would love for you to comment on anything I shared.
Thank you, Ray. Yes, I am on the line. I have to say this has just been, first, let me start out. My name is Jennifer Fletcher. I'm an RN on the community health team at Virginia Mason Franciscan Health here in the Puget Sound region of Washington State. This has just been really enlightening work and such important work. And one of, I think what we discovered here in our region, and I would say with Common Spirit at large, which, as Ray said, is kind of the parent company of Virginia Mason Franciscan Health nationally, it has been, while we haven't been successful in executing formal contracts with local CBOs, this has been an amazing learning experience that we have gotten from the ACL Care Transitions Echo Series. So whether it's greater conversation internally within our healthcare system here, we've had a number of folks, whether it's in the Issaquah region or even over in our Kitsap County region, we've really had increased conversations, not only internally, but with local CBOs. And even one area where we had the potential, I think some really great potential in conversation to do some formal contracting. Unfortunately, that CBO just didn't have the capacity to formally join, this cohort. So again, I think the great learnings that Ray already shared, in addition to ours, which was great learnings across the board, but absolutely good partnerships and relationships. What a delight it's been to start to work with Ray, introduce him to some of our clinical leaders in the Issaquah area, where he could at least begin some conversations, and having the engagement with our community health team has been just a wonderful start to this work. So Ray, thank you so much.
Thank you, Jen. Next slide, please. So the partnership building, so hugely key. And I think for me, a lesson I can share is, or something I can share with the broader audience is, connect with your civic leaders in your area. Because for us here at the city of Issaquah, I mean, we have licensed case social workers that actually monitor what's going on in the community, seeing if there's homeless out there who need assistance. So there's resources available to organizations from a civic perspective, not only the community-based organization or the healthcare delivery organization that resides in the region, but also consider contacting that civic leader, whether it be a city council member, the human services department that serve your region, because I think they might have resources to align. Nationally, I was fortunate enough to attend the 2024 CMS Health Equity Conference in Bethesda, Maryland earlier this year. The work that we're doing here certainly has the attention, as I think we've all been educated by federal eyes. CMS was presenting there, and they also had folks who are presenting as far as the final rule. So that was really helpful. So I know that this is happening at a national level, and we have the attention of others. But what I asked that group there, interestingly, is, should we be concerned that this work might change or change direction based on the fact that this is an election year? And they were honest, and they said, perhaps. They didn't give me a yes or a no, but the work that we're doing here is key for us. So understanding what's happening from that perspective, I think was important for me to just get an understanding. Regionally, I talked about these CBOs. The one that I work closely here with, that is in touch with lots of nonprofits, is called the Nourishing Network. I presented to their organization, and I asked them, with folks that you service in our region, what is your connection to healthcare providers? Are you connecting to them? Are you having to take them to the ER because of an emergent situation, or have they, meaning the healthcare facility, reached out to you in any form? And that was the homework I gave them. If that does happen, maybe we can dive into that a little bit more. Is there continued outreach that's occurring between that healthcare provider and you? Because perhaps we can talk about setting that contract that we were talking about. So their eyes and ears are aware of what's going on here, and I'm hoping to continue that work further. The healthcare delivery organizations that are physically present in my area, they're large and small, as I labeled here, national and local. And again, calling out Virginia Mason to come together with me to continue this work. But I've contacted with all of these, and I think what might be a good strategy is for those organizations that have a very large footprint, understand what their larger strategy is and how it connects to you locally. I mean, they are aware, those that I have listed here, to reach out to me and say, hey, I'd be a willing partner for you, healthcare organization, should you want to consider this effort, and perhaps consider creating a pilot contract so that we can continue this great work. So I just wanted to call those out. They've been willing to listen, but there have actually no been contracts that have been made, but I'm going to continue to pursue that. Next slide, please. I want to look at this. So where am I going to take this information next? I think from strategically, healthcare organizations, as we know, continue to make DEI as an imperative. So this work aligns greatly with that work. Connecting and educating additional CBOs. I talked about that meeting that I joined monthly. There's always a new organization that's fascinated and interested in this work. I'm going to continue to ask them the question, what is your interaction with healthcare providers? And can we dive into that a little bit more and see where this program might line up well? And then informing local civic leadership. I mean, I have their attention here locally, but I've also reached out to our larger neighbor, which is the Seattle metro area. And surprisingly enough, some of the folks there weren't up to speed with this. So it was nice to connect with them and say, hey, let's talk more if we can maybe connect with them on a broader scale. The challenges, I think, as I mentioned in the previous slide, the contracts, you know, they can get complex. Thank you to the ACL team for providing the sample contracts. That's been helpful, but we know with large organizations, complex contracts can get complex. But the HIE and CIE, the health information exchanges, and these community information exchanges, which fascinate me. If data here is going to be key, right? How do we exchange that information in regards to the provider's workflow? How do they communicate with the community-based organization? It's quite complex, so I think there's going to be a little more deep dive that needs to happen there. And there's just a call out, I don't know if any of you subscribe to this magazine, but the work that's happening here certainly is in the forefront of a lot of the strategy that's going on with healthcare executives. I call out in bold, they're realizing the need to reach beyond their own four walls to truly capture and address the needs of the populations within their communities. I mean, what better way to describe the work that we're doing here? And it's nice to know that leaders throughout many large organizations are aware of this. And then retrospectively, my last slide, Doug, this has been something I've been very passionate about. This has been ongoing. I participated in writing an article for Healthcare Executive, and I specifically called out the work with Community Investment Partnership is going to continue to grow, and we need to have our eyes and ears on this, because they need to be partners, not only like the previous slide said, not only the folks in the four walls of the hospital or the ambulatory clinic, but those other partners in the community, that homeless shelter, the food bank, et cetera, they are a part of the larger picture here, and they need to be in the know. Thank you
Thank
for
you
this.
so much. Thank you so much, Ray. Lots there, and great journey, and glad you were able to bring in a colleague. With that, I would like to now turn it over to our Illinois team, and Dana and Peter, it's all yours.
Great. Thank you so much, Heather. I'm Dana Franceschini. I work with Coordinated Care Alliance, which consists of a network of community-based organizations in Illinois that serves older adults. And we are partnering with Ascension St. Mary's Hospital to implement a transitional care model, which I can talk about more on the next slide. So we were fortunate to be able to get some funding from the Illinois Department on Aging to implement the Enhanced Choices for Care program. And so anybody that is 60 and older that's going to a skilled nursing facility needs a assessment completed, and during that, their choices for care are explained to them. And so this was a great segue into doing a transitional care model. So we have 2 different organizations at Coordinated Care Alliance that are implementing this program. And so Ascension St. Mary's is implementing with Catholic Charities within Illinois in Joliet. So we began the program a little over a year ago, so this Echo series was very timely given our partnership with St. Mary's. So for the process, we have established, we receive referrals from Ascension St. Mary's Case Management Department for anybody 60 and older that has an identified social need. And then from there, we initiate the bridge model of transitional care, which is a 30-day transitional care intervention. It's housed at the Center for Health and Social Care Integration at Rush University Medical Center. And so during that time, Catholic Charities will do a bedside visit with any of those referred clients to explain the program, and then follow up with them once they discharge within 24 to 48 hours. And also trying to do a home visit, so being that eyes and ears into the home to really make sure they're addressing any of those unmet social needs, and really working closely alongside with the case management staff to address any gaps in care, any medical needs. So there's continuous communication between case management and the Catholic Charities care coordinator. And so during that 30 days, the care coordinator continues to check in with the client at least once a week, if not more, completing a full-length assessment, determining any goals that they would like to meet during that time working together, and then really trying to get long-term services and supports in place by the time that their time together has ended. So Catholic Charities and the different community-based organizations that are a part of membership for a Coordinated Care Alliance provide services through the Illinois Department on Aging, so they can provide a warm handoff for older adults to get services through the Medicaid waiver program, home delivered meals, caregiver support. So really any of those things. The care coordination staff really work collaboratively together at Catholic Charities to meet those clients' individual needs. So since the partnership has progressed within the last year and through the Echo series, we've been working closely with Pete and his staff to continue to increase the referrals that we get from the hospital, really to make sure that we are trying to close any of those gaps in care, and making sure we're meeting the needs of any of those clients 60 and over that come into the hospital. We've also throughout this time recently have been really focusing on data reporting and sending updates and data sheets to Pete and Ascension St. Mary's staff, just really reporting on any of those like processes and outcomes metrics that we have to show the value of this program. And we've been able to, during our time in the Echo series, work with Pete to get readmission data on the clients that have we provided their intervention to, which then we've been able to show them how it has impacted readmission rates. So it's allowed us to continue to have dialogue with Pete and the St. Mary's staff to continue to be able to grow the program, make it more efficient. And we're continuing to do that as we move into this second year of our funding. So this is our last year of funding through the Illinois Department on Aging. So in terms of future plans, we're really trying to look at continuous expansion of data sharing and how we can come together to be able to have more of that open dialogue and communication to report on more of those process and outcomes metrics, and then also looking at ways in which we can sustain the program once funding from the Illinois Department on Aging has gone after next year. So looking at the different codes and other mechanisms out there to make sure that we can continue to sustain it for the future. Now I can turn it over to Pete, and I know we have some other folks that are part of the partnership on the call too. So Pete or anybody else, if you'd like to chime in, you're welcome to do so.
Dana, this is Pete Lamont from St. Mary's in Kankakee, part of the case management department. I'm a social worker by trade that's been here for 35 years and counting now. So, but I've been working closely with when Dana and Bailey came forward with the funding. It was just great news. And then Leanne Gregoire and her team in the trenches doing the hard work every day. Seeing the results so far has been fantastic. I still feel like we got a lot of room for growth. Our referrals do ebb and flow away too much. So it's kind of like the carnival game whack-a-mole. There's a lot of competing priorities. So just trying to stay on top of my team to make sure that they remember to refer patients to the program. And then just data sharing. I wish there was we had electronic medical record and other ways that we could share data a little easier than doing a lot of background work, but it's been a great partnership, and I'm really excited for the upcoming year because I feel like a lot of the kinks kind of it's gotten worked out, not just hard work with Dana and the team, but also being a member and attending these ECHO series. So thank you so much.
Thank you both so much, Dana and Pete. It's great to hear from your journey as well. What I'd like to do now is turn it over to Lisa from Elder Options. Lisa.
Thank you, Heather. Thank you, John, and everyone for being here. My name is Lisa Kanarak. I'm the Director of Marketing Communications at Elder Options. We are a AAA based in Gainesville, Florida. We cover mid-central Florida from the Villages all the way up to the Georgia state line. And I'm joined here today on this call by Amy Thomas, who is somewhere in there. Can you change the slide, please? We have been in the care transitions field for the past 10 years. There was a federal grant that allowed us to enter the field, and we have been working with the University of Florida. Our success has resulted in reduced 30-day readmission to 5% or less for patients with chronic health conditions. And we're often able to lead these patients into some of our evidence-based programs to continue the program. But because this is a grant, there is a lack of stability. So we were really excited about joining this ACL process to learn about billing for these services and also expanding our services into other fields and not just working with the one hospital. So ironically enough, one of our graduates of our care transitions programs daughters was working for a brand new home health agency in the area, and she remembered how great we were to work with. So she said, hey, we've got this new home health organization. We hear you're doing good things. How can we work together? So we figured out the data that we could put together and started meeting with them, pouring over CMS papers, going through the steps, learning, I have to say, learning what so much, data with an exclamation point, because it is so many types of data. It is not only the health information exchange data, Epic, what are we transferring back and forth? What information are we collecting? What information is our partner looking for? What information do we present? How do we present it? I wrote in there medical versus nonprofit social services language. We talk about clients, we don't talk about patients. And what was really great was a member of our team, Amy, managed to really spend some time with the SDOH codes and drew a chart to getting them into the billable diagnosis codes for the Z codes. And that really got the home healthcare agency very, very excited to see finally, okay, this isn't just a whole set of codes. This could turn into something that we could bill for. The charts from Tim McNeil were outstanding for understanding how and when we can open the door for those CHI codes or the PIN codes. And of course, understanding the closed loop referrals. And lessons learned. Well, our big lesson, we were so excited with home health. We met with them a few times. We set up a meeting with Heather and John. And as soon as the word Medicare B was said, they said, oh, well, it's been fun and exciting and we've learned a lot, but we don't bill Medicare B. So that was a big lesson for us. It not a bad lesson. It was still great to have to go through the process with somebody and do the dance and learn what they want to learn. And going forward, we've actually met, there's a brand new accountable care organization here in town through the University of Florida. So we're in the process of meeting with them, and a new PACE provider is coming to town. I don't know if anybody here is working with PACE providers, but we are trying to get a meeting with them as well. So lots of lessons learned about knowing where you're billing from.
Wonderful. Thank you all so much. And I know that we're going to be coming close to the top of the hour here. What we'd like to do, if we move to the next slide, is I'd like to just quickly share the Menti results. And we have another question we'd like you to just pop in. We're going to build a word cloud. And what I'll do actually is, if you could give me permission to share, I'm going to read some of the inputs that you've all shared with us so far about the valuable lessons, tools, or strategies you've learned to this with this series. And what I'm happy to share is a lot of billing codes, partnerships. We loved seeing that you are looking at using the resources, learning to adjust language to the healthcare system, translating CBO language and processes into healthcare language. So there's a lot of learning around language. So we'll package this up with the slide deck as we put this out to you on the TA site. But what we would like you to do is go back up to the Menti poll and put in how you're feeling right now. We would love to have you, I'm going to go back to that. We're going to ask you to build a word cloud with us and share one word that describes how you're feeling because of this ECHO series. And as this is going, I'm going to actually turn it back to John, who's going to take us through some wrap up, and I'll stop sharing, but we'd love to build this word cloud and have it be shared with you as a celebration of all of your wonderful efforts. We truly, truly appreciate what you've done over the course of this series. John?
Yeah, I couldn't have said it better, Heather. Thank you so much. We'll just go through the wrap up very quickly. Just next slide. I'll go ahead and give Monet a second to transition over, but there we go. As you all know, I'm going to continue to exhort all of you to please register for the TA community site to gain access to all the resources and materials that are out there. As I said before on the next slide, we really built out the resources slides for this session because we wanted to kind of put so many of the great things that were shared into these slides. The TA community houses a lot of great resources about Medicaid claiming. So there are links to a lot of those resources here, along with general links on resources around sustainability. We know how key that is. If you go to the next slide, these are a stack of CMS resources pulled from previous sessions. Again, just trying to provide a one-stop shop for you. And then the final slide here on the resources. For those of you, if you weren't aware, we did pull out speaker presentations, dedicated speaker presentations, and posted those on YouTube. Those are publicly available. You do not need to be accessing them through the No Wrong Door channel on YouTube. So these are the links to the dedicated presentations. You can just search for them in YouTube and pull them up and share them. We just felt like this was content that was worth sharing. Next slide. It wouldn't be a session without the post-session survey. We are not skipping that just because it's the last session. In fact, we want your feedback even more. If you have successes or challenges that you want to share, please share them in the post-session survey. We want that opportunity to hear from you. And if the post-session survey, if you're not ready to share all that, but if you think of something later, please let us know. If you can go to the next slide. You can email us at caretransitions@lewin.com. And I know we're at the top of the hour, but I would not be doing my job if I didn't extend a sincere thank you to everyone who's participated in this. The intent of this whole series, both the main sessions and the peer sessions, was to give you a chance to hear from your peers and to learn and to share experiences. And we hope that you've taken away some knowledge and connections to support your work going forward. It's been said more than once in this session, the road does not end here, and it does not. As you know, you have the opportunity to go back to review information and reconnect with some of the people you've heard from. We're all in this together, and it really speaks to the core message behind an ECHO series. It is an all teach, all learn environment. Please continue that teaching and please continue that learning. From the entire Care Transitions team, from all of our presenters and from ACL as well, we want to extend our sincere thank you for all your efforts and all your continued participation. Reach out to us if you have any questions. Thank you so much. Have a great day.